Good evening and welcome. This is Stepping Forward with Dr. D, and we are on blackdoctor.org where wellness and culture connect. A little bit about me: I'm a board certified podiatrist and I work for a federally qualified health center in Northern Jersey, Neighborhood Health, giving care to all, regardless of insurance status. I am also the co founder of Sisters in Podiatry, a Facebook group for Black women in podiatry in the United States and the Caribbean, and your host tonight for the premiere of Stepping Forward with Dr. D, which is your gateway to all things podiatry. So you ask, podiatry? I didn't know Black podiatrists. What is a podiatrist? And we are the medical and surgical specialists of lower extremity. Bunions and hammer toes, we've got it. Diabetic foot, we've got that too. Summer pretty feet, come to us, and reconstructive surgery and more. I created this platform as I thought it would be wonderful for the Black community and those who support us to have a comfortable space to listen, to learn, and be heard. So grab your favorite beverage and let me introduce you to our guest. Before we do that, make sure you're sharing this content. And also in the comments, let me know where you're from. I'm hailing from the Northeast in New Jersey, and we want to hear from you. So I have one of my first guests on who's absolutely fabulous, and I call her a friend as well. Her name is Dr. Yolanda Ragland. And I'm going to read her bio because it doesn't do justice. She's a podiatric surgeon with her education with a Bachelor of Science from the University of Maryland, College Park. I'm going to tease you and say the other UM since I'm University of Miami. During her tour at U of M, she completed a fellowship in dermatology branch of the National Cancer Institute under Dr. Stephen Katz at the National Institute of Health. She obtained her DPM, or Doctor of Podiatric Medicine, from my school as well, the New York College of Podiatric Medicine. She is certified in surgical training through an academic affiliate of Weill Medical College of Cornell University. She maintains her fabulous office on Park Avenue in New York City and Washington metro area, Bowie, Maryland, DMV. The focus of her practice is bunion and hammer toe correction. Her trade secret, tiara toe, which has been trademarked, technique leaves patients with sandal-ready feet and visible scarring that you just can't see. Dr. Ragland's goal is to help women be successful by supporting them with a strong foundation. She likes to say, I know what it is to walk in your shoes. And she understands that women of color, particularly Black women, suffer from bunions, horns, and hammer toes, and has the techniques and treatment for you. In addition, she has been featured in Allure, she's been featured in Insider, US News, Bustle, and much more. It is my pleasure to introduce Dr. Yolanda Ragland, aka Queen of the Toes. Hey, Yolanda.
Hi. Hi, Dr.
You like that introduction, correct?
That introduction was wonderful. Thank you so much. And thank you for having me on your show. I believe I'm one of your first guests.
You are one of the first guests. Our second guest hopefully should be logging in a few minutes, but we're going to start with you.
Okay.
So let's bring it all the way back, Yolanda, back to Harlem, New York, where we were at the New York College of Podiatric Medicine, thinking we were big stuff and we were going to do big stuff. And I think we did. So tell me, why podiatry? A lot of people ask me. I met someone today who said, I looked up a Black female podiatrist and was so happy that I met you. And you guys are unicorns because I didn't think you existed. And I'm like, really? We have Sisters in Podiatry where we're across the United States and the Caribbean. But tell me, why podiatry for you?
Well, as you read off from that wonderful list of accolades, I did do research in dermatology, and I actually thought I was going to be a dermatologist. And I was getting applications from podiatry school, and I was throwing away the applications because I did not know what podiatry was. And so as I was about to throw away another application, one of my girlfriends came and stepped into the lab and said, what are you doing, dum-dum? And I'm like, I don't even know what this is. And she's like, it's it's medicine. It's a school of medicine. She goes, there's hair, skin, and nails on the foot. So if you want to subspecialize in dermatology on the foot, you can do that. And I loved the whole idea of subspecializing in what podiatry is a subspecialty. So I thought that was wonderful. Plus, I had sold shoes for many years. And so feet never bothered me. Some people are just grossed out by feet, but feet don't bother me. And so I was, hankering to go back to school and further my education. And they were accepting applicants, and they came to actually Washington, D.C. And I applied and I got in, and that started the road to my podiatric career.
Wonderful. I have my second guest who we're going to find out what made her go into podiatry. And I'm so happy to bring together these two ladies. I am bringing forward Dr. Ebony Vincent Sleet.
Hello,
Hey,
everybody.
Ebony. How
Hi.
are you?
I'm good. Thanks. How is everybody
Fantastic.
doing?
So I'm going to read your bio because you're fabulous too. That's what we do. So Dr. Ebony Vincent, DPM, is board certified, highly trained in foot and ankle surgery in Orange County, California. Hi to everybody on the West Coast. She has an extensive experience in the latest treatments for foot and ankle conditions and specializes in minimally invasive surgical techniques, corrective and reconstructive foot and ankle surgery, diabetic limb salvage, pediatric foot conditions, and sports medicine. She completed her undergraduate. I know my folks who hear this will be happy at where? Hampton University, and a master's of biomedical science at Philadelphia College of Osteopathic Medicine in Philadelphia, and completed her DPM or podiatry degree at Des Moines University in Des Moines, Iowa. She did a 3-year residency at Inspire Health Network in Byland, New Jersey. She was trained under top orthopedic and podiatric physicians in advanced treatments for children and adults with upper and lower limb length discrepancies, limb deformities, non-unions, bone defects, bone infections, and more. She has published several articles with the Journal of Orthopedics and Sports Physical Therapy. She serves as the vice president of her local Orange County Podiatry Medical Association, which is amazing, and is a board member at large for the California Podiatric Medical Association. But where many of you know her from, because we like TV and media, and hence our show, is that she stars on the hit TV series My Feet Are Killing Me on TLC, which has enjoyed 5 episodes, and she loves making an impact in her community. I met Dr. Vincent when we were at a course for one of the companies that we use for bunion surgery. And it was amazing as we had many Black women show up to this and we clicked. And she's also a member, just as Dr. Ragland is, of Sisters in Podiatry. So, Ebony, I pose the same question. Girl, you hear about podiatry. Why podiatry? What was your journey?
I always tell people that I feel like podiatry sort of found me. I was always an athlete, did, lots of sports as a kid, and I had my own bout of injuries. So I had undergone 2 ACL repairs, went through the whole surgery, physical therapy gambit, like you name it. I've done it when it comes to athletic injuries. And so I honestly started off wanting to do sports medicine, and with the mind of maybe I'll do orthopedics. Podiatry found me when I was at Philadelphia College of Osteopathic Medicine, where I did a lot of shadowing. Because I did volleyball in undergrad, I still needed pharmacology or biochemistry, like one of those 2 classes. I couldn't immediately go into applying for medical schools, which was actually a blessing in disguise for me. So I took the time to do a master's program, and I had the time to really shadow other doctors, to really be mindful about picking a career, because it sounds nice, when you're an undergrad, like I'm going to do this career or whatever. But when you get a little older, more mature, you actually kind of look at these people's lives and see what kind of lifestyle they have. Is it diverse? Do they have families? And when I did my shadowing, I shadowed a podiatrist and I really, really liked it. Like I don't mind feet, obviously people have like foot fetishes or phobias or something like that. But when it comes to health and wellness, everybody's sick. Nothing's beautiful. Everything smells bad. Everything looks bad. You just have to be a type of person that doesn't mind helping people in their time of need, which is oftentimes not pretty. And so podiatry, it definitely fits the mold of not being pretty, but also it fits the mold of you having made a difference in somebody's life, you
Absolutely.
specializing, you being able to have more control of your life on a day-to-day basis if you're a practice owner. There was just so many upsides to the field of podiatry that when I found this career, it was like a no-brainer. I'm like, oh, of course, yeah, that makes sense. Like, so that's podiatry definitely found me, but then I found the golden goose, I guess, in podiatry as well. So
Absolutely. My story is I wanted to be a psychiatrist, I think, in the beginning. And I had someone I knew who was committed, and it turned me completely off. And I had a full scholarship undergrad. And I told my parents, I don't know if I'm going to be a doctor. And my West Indian parents looked at me like I lost my mind. Yolanda, you can understand. And podiatry, it happened that my mother had hammer toe surgery, and it was a professor emeritus from New York College of Podiatric Medicine. And I shadowed him, and he was just like, don't you see all these white men in the career? Why do you think we're doing that? And he talked about quality of life. He talked about, different aspects of podiatry, surgery, as we all do here. And I was like, this is a great idea. And I went into it. So as I did that, and I was able to did residency as everybody did, and practiced in New York for years, became an associate, then a partner, then came to New Jersey, worked in with Lowell Wild Jr. That was fun in New York. And then we did worked for a multidisciplinary group for 7 years in Northern Jersey, and now being the podiatry director for a federally qualified health center where I can give care to everyone, regardless of immigration status or insurance. So that's my story. But I want to hear about your practices, and then I want to hear about some of the struggles that you faced in podiatry, and then we'll go from there. And I'm sure we'll get questions as well. So Yolanda, yes, my dear. So I want to know, your practice focuses on strictly surgery. Tell
Right.
me, you said that's right. I want you to tell me, what does that mean for, we have a lot of medical professionals watching, I'm sure, but we have a lot of everyday folks who we love that are our patients, our friends. And why surgery? And tell us, what does this practice look like? Because we see the fabulous pink in the background and your hair. So we want to hear, what does this practice look like? Because I'm sure people are coming by just to be nosy now on Park Avenue to see your practice. So tell us about it.
So my practice is, I call it a niche practice. It is strictly surgery, but it's even more focused on just the forefoot. So that's the front part of the foot for those that aren't medical professionals. And I do concentrate on correcting bunions, hammer toes, and corns with a cosmetic result, because what I was finding, excuse me, especially during my residency program with results, was that the results weren't translating the same on Black skin as it was on the majority. So I was like, and I would have also ladies would also approach me and ask me, hey, isn't there another way to do this? Because they either had a friend, a mother, an aunt, someone that they knew that had some sort of corrective forefoot surgery done, but they had a scar that left them saying that, you know what, I'll stick with the pain. They would rather keep the pain than get the corrective procedure and be left with the scar. I think what a lot of people don't understand is that the unsightliness it also leaves you with another medical condition. It's mental. And in not in a funny way, it's very serious. I have boxes of tissues all over my office because of the trauma that a lot of these women have gone through after having medical procedures from people that just do not understand the demographic of patients that I deal with primarily. It's not that my practice is for everybody, but I think that people tend to gravitate towards what they're familiar with. And so a lot of my patients look like me. And so I have developed procedures and techniques um, to reflect an outcome that is desirable for this particular demographic, which will actually be desirable for any demographic. So I feel like my practice is really all inclusive, even though I do strongly talk about working on women of color. It's definitely an inclusive group, but I did think of this demographic first because they were
They're
never
you.
thought of. They were never thought of, and I wanted to provide this particular demographic with the procedures and techniques and services that they actually deserved.
Absolutely. Absolutely. So and I'll come to you, Ebony, in a second. I also do cosmetic incisions. I've been published in my cosmetic incisions in podiatry today. And that was one of the big things. Again, Yolanda and Ebony, you have a bad hammer toe. Everybody knows that little crooked toe that you need to fix. We know it's you. And now you have this ugly scar going either up your toe or across your toe. Then you can't be, my sisters who like fashion and little Gucci sandals and their UGG sandals and what have you. Now you're like, ooh, I hate this. Then you come and you say, what kind of fade cream can I use? And I'm like, there's no fade cream but Jesus that's going to take away that scar. So we
And
have to start thinking differently, particularly I think on everyone, but definitely on our patients of color because of the risk of hypertrophic scarring, which is more advanced scarring, and then good old keloids, which unfortunately many people of color suffer with.
And
Ebony,
then
I'm sorry.
I do want to add to that. On top of
Mhm.
that, it's not just hypertrophic scarring and keloid scarring. It's just actually just leaving permanent marks there.
On the foot.
So it's
Mhm.
also it's the materials that you use,
Absolutely.
and it's the techniques and how you close. I see that there are other doctors out there, and I'm like, look at how they use so few stitches. They're so wide up. I look at the techniques, and they wind up, even though they're doing the incisions in the correct decision in the correct direction to optimize what the incision result will look like.
Mhm.
These patients are still left with what I call zipper lines on their toes. So there's so much more. It's not just knowing which direction, it's how you throw the stitch, how many stitches you use, what needle you use, how small is it. I would say that I probably spend more time closing than I actually do
I agree.
doing the bone procedure, especially if the closure is something that they are going to see. If it's a hidden incision, I might not spend as much time on those
Mhm.
incisions. But if we're going to see that incision, so there's a lot more to it than just hiding it, or if it's
I
which
agree.
direction it's going in.
I agree. I know, Ebony, you work with residents, correct?
Yes, sometimes at the hospital.
Okay, so I know that sometimes the residents are like, I've got it. And you're like, wait, hold on. Because sometimes we want them to learn. They're the next generation. We also want, as just as Yolanda said, to make sure they're taking that time and we're teaching those techniques for them to close correctly. So tell me
Yeah.
about your practice.
So my practice is definitely more of a mixed bag. I don't necessarily specialize in any particular surgery per se, although I do see my fair share of bunions and hammer toes. I live in California where everyone walks barefoot all the time, every day. So I do deal with a lot of sports injuries and a lot of your more regular podiatry kind of things like fungal nails, ingrown toenails,
Mhm.
corn calluses, like everyone's out here with their feet on display 12 months out of the year. So I'm definitely dealing with all things. Um, with the residents specifically, I do a lot of surgery, whether it be like neuroma excisions or soft tissue tears that need to be repaired. This last Friday, I did 3 lapiplasties, Corday.
So
And
hold on now. Everybody's like a lot, and you know what, audience, if you have questions, I know she threw a big word, lapa who? Lapoplasty. Please put your questions, type them in, and we will answer them. But tell us what a lapoplasty is, Dr.
Sure,
Vincent.
sure. So a lapiplasty is a technique for a lapidus bunion procedure. So if anyone has bunions, this is the procedure of my choice to do. I it's they don't have a minimally invasive way as small as I would like it to do it.
Agree.
To nod to what you guys were saying about the scarring, but technique wise and biomechanic wise, I do believe it's the best way to fix a bunion. And I'm the type of person that doesn't want to do surgery on someone unless you're in pain. It doesn't make sense for me to convince you to go through a long recovery process to heal your bone in 8 weeks, to go through the nerve pain, the swelling, and you not like exercising and doing all those other things unless you're in pain. So absolutely, I see a lot of really terrible feet, especially since the
Hence
highlighting
the show,
kind
Fix
of
Your Feet.
yeah, the show definitely brought in a lot of interesting foot types. So I'm not one to back down from a challenge. I will say that the utmost priority in my practice is to get people back walking again, whether it be large incisions or small. I always talk to them about their recovery and make sure they understand, like, hey, you got a foot that there's no way of minimally doing anything. Sometimes you'll have more than 3 incisions on your foot in order for me to get you back walking. If you're okay with that, here we go. But hopefully one day I will be like Dr. Ragland and be able to be more specific with my practice. But right now, the way that my practice is set up, I am with a group practice. And we have about 5 offices, and I work in between 2 offices. So right now we're building the practice. And then hopefully later on in my career, I can be more selective, more specific, and do more of the minimally invasive things as I want to do. Because like you both, I do want to specify on beauty. So that would be great.
Sounds amazing. I like dealing with our patients of color. I also do some procedures in the Caribbean, especially, women of color. Skin of color is a different type of animal, and you have to be nurturing. You have to be understanding. I love that, Yolanda. You said you had tissues in your office, because it is, it does come down to sometimes people being very emotional about how things look. I mean, look, our society is definitely a see me society. And definitely if you're showing off your foot, you want to feel, that you're putting your best foot forward. So let me ask you guys, now that we've heard about your fabulous practices and all that you do, tell us about some of the not so fun stuff that has happened in podiatry, maybe along the way. Some of the things that made you get your grit, as they would say, or built your backbone. And you can say, I went through it and here I am. Yolanda, you start first.
Oh, well, I mean, look at me. I'm the Black lady with strawberry shortcake pink hair. um, so, and I just think it's crazy. But, I get judged just based on that. It's the judgment. Um, the patients, they find me on Instagram. I would say it takes on average patients about 2 years to actually make that move, to actually have the appointment with me, to move forward, to have the surgical procedure done, which is understandable because you don't know if it's a gimmick or if I'm real or whatever. So they want to make sure that it's the real deal or whatever. But they'll still come in and they'll say, are you doing the surgery? So, I mean, like, that hurts. And I'm typically like this joyful, happy person, but I have feelings too. And like, that hurts. Yeah, I'm doing the surgery. And just like Ebony, I have residents that scrub in with me. Now, I don't allow my residents to really do much. And I explain to my residents that these are very private patients because I am a non-par. I don't participate with insurance plans, doctor. So these patients are super private. But I feel like they do get to learn by seeing procedures done in a very unique way that they're not going to see anywhere else. So they do get to learn that way. Let's see. And then the other thing is just like, working in, I've been in Manhattan for the last 18 years. And the thing that really hurts the most is that I have not seen not just podiatrists, just other Black doctors or other Black surgeons in the ORs. I'll tell you the other Black doctors that I see in the ORs. I see anesthesiologists, and if I were to use a hospital, which I avoid like the plague, but if I were to use a hospital, I will see OBGYN. But I do not see other Black surgeons. And I'm talking about male, female, whatever. I don't see other Black surgeons. And that's not fun. So when I come in and I need a locker and they're telling me that there's no locker for me in the women's doctor's room and they want me to go into the nurses' locker room, that's not so fun. I mean, there's a lot of that. I just heard a woman talk about this on the radio, another Black doctor, and the same exact thing happened to me. That happened to her, parking at a parking lot at a doctor's building in the doctor's section, and another doctor got out of his car and told me this is where the doctors are supposed to be parking. And I must have had a day because I was just like, you need to stick to what you do, which is doctoring. And I said, because there's somebody else here. There's somebody here that's in charge of the parking lot, and it's
not you.
And I'm being very nice right now when I'm telling you what happened, but I went for the jugular. I was a mad dog, and he ran off with his tail between his legs because, excuse me. So don't let the pink hair fool you.
I'm laughing. I'm so sorry. Ebony.
Well, the microaggressions are there from literally day one. I mean, you go to, I mean, coming from an HBCU where you're not the minority to going to levels of higher education where you're definitely the only sometimes in the room. It's, you learn to deal with microaggressions on a daily basis, but challenges in medical school for me, just being the only person in the classroom that looked like me. The sad attempt at DEI was just, it was met me with more like angst in my heart than anything else. Cause I'm like, oh my God, like, why are we talking about CP time in a medical school class? And I'm clearly the only person of color in here,
We're talking about you.
About me. Like, then as you matriculate through residency, I was the only woman and I was the only Black person in the entire residency program for my whole 3 years there. Like, I definitely faced some microaggressions, challenges, from my peers, from other attendings. So it's kind of a dogfight for like the first, formative years. And then, now in my career, I feel like there is a level of respect that I've basically just like kind of tooth and nail, just got it. And professionally, I feel like my challenges now are more so medical when it comes to having hard conversations with patients. For instance, like, people see things online or on TV, or they'll see me advertise something and they come in with the idea that they can have this procedure, and I have to explain to them the science behind it, and like, no, you're not eligible, and then there we go with the tears. And I thought that doctor was going to do something, like, you kind of be putting on this pedestal, and like, I'll just, for instance, there was a woman who had a congenital deformity. She didn't really have any toes to work on, but she swore up and down that I could do something because she saw me on TV and miracle worker, I could do something. And I had to tell her, like, unfortunately, some things just happen, you have to live with, and like, I can't work with no skin and bone when there's no skin and bone, so yeah, challenges like that definitely happen. So dealing with the medical side plus the microaggressions continuously, it does weigh on you. Overall though, I think that a job is a job. You're never gonna get around a lot of the things that we face every single day. And at the end of the day, I do enjoy being someone who can be relied on to take care of people. I enjoy being a caretaker, so I have more wins than losses, and I just have to continue to speak positivity into the career itself. So definitely challenges on a daily basis, but overall more positive than negative.
I will add to that. I was the first Black female podiatry resident for my program, and my program is pretty old. So I was just like, what? And that was a time, Yolanda and I are at the same time, where you didn't automatically go to surgery. It was picked, so you had to put in, it was a whole different ball game. So that was hard in and of itself because I had microaggressions and some macroaggressions definitely during residency. When I became an attending, a lot of times I worked with, my business partner was not Black. And so a lot of times he could be wearing scrubs and I would be dressed up and they would think I'm the nurse or his assistant. And I'm like, no. Or even, and not even sometimes from our own Black people. I remember being in a hospital, and granted, we've good skin. Okay, I'll take that. And I had gone down to tell the surgical staff in the hospital that I was going to go up and get the patient because they were backed up, and they were very grateful for that. I went up and met the residents. None of the residents are African American, none. So it's me, and the nurse is having a fit. She don't know where the doctor is, and she needs to come on. And this patient's been waiting, and my residents look terrified, like, oh, this may not end well. So I walked and I spun around and I said, well, that would be me, darling. And since I run this, read the note because the order's in the system. Are there any other questions? She came to me later and was like, oh, I didn't know you were the doctor. And I was like, why? Too young, too female, too Black. So it happens even within our own communities. And, again, the unicorn, there's Black female podiatrists. Yes, we exist. Black male podiatrists. Yes, we exist. But I've always tried to I love working with people of all backgrounds. I especially like working with women who look like myself. And I think I'm the ultimate networker where I try to bring people together. And I think there's a commonality that we all have, regardless of race, regardless of ethnicity, regardless of sex. And that's one of the things that I like. This show, you'll see a variety of podiatrists, even though our focus is the African-American community, because I think we all have something to contribute. So with that being said, I know, my surgical sisters, that there are procedures that you love and, certain products you like. I've had the conversation with you. So I'm going to flip it because I keep going to Yolanda. Ebony, people on here, we have some bad hammer toes. I mean, y'all know sometimes you shouldn't be wearing open toe sandals. My former pastor used to say, sandals is a privilege, not a right. So therefore, you need to come to one of these ladies or myself to get it fixed. So Ebony, somebody has hammer toes or a bunion. We'll stick with the forefoot for right now. And what kind of procedures are you offering? Because some of these things, are being advertised, and that's why you have people going, ooh, what's this? I want that.
Right.
They may not be a candidate for it. So give us a couple of things in layman's terms that you use.
So it really does depend on the patient's condition. So first you got to do your physical examination. If there is someone who has a flexible hammer toe deformity, I'm usually
what does that mean?
Oh, sorry. I'm talking to you guys. You know what I'm talking about. We're talking about the audience. I know. Okay. Flexible meaning it's like you can still bend the toe like up and down, if it's flexible, but sometimes it just rests in this hammered position. Then I will start with just soft tissue procedures, and I can do that in the office minimally invasively. So I can numb up the toe and do a flexor release and have that toe straight.
What's
Then,
a flexor release?
I basically loosen the tendon on the bottom that's contracting the toe downward. So I just cut it and it goes right straight and it's fine. For people who have rigid deformities or are stuck, like in this position,
That's what we call hammer time.
this is what we have hammer time. And they usually have like little corns, and maybe sometimes they tried to put like little salicylic acid patches on them. And especially for people of color, like if their skin is brown and then that little corn is white, it looks terrible and it's painful. Those people I am taking to the OR, I'm taking them to surgery. I am a fan of implants. I like to use toe implants because I find I have a better result with them for the long run. It definitely, I do take insurance. It does depend on the patient's insurance on which implant that I can use. But lately I love using Osteo. They have toe implants, and they also have like a 3.0 nail that I can like make into an implant. For those of you who don't know what Osteo is, it's basically the same density, same material as your bone. And when you implement it into your body, it absorbs. Like your body will absorb it, or absorbs probably not a better term, but it becomes bone essentially. So you can't see it on x-ray. It's not metal. It's not something that can loosen, or if it does loosen or break, it just like gets absorbed. When it's metal, you actually have to physically take the metal out and do wonders in order to fix it. Using Osteo makes it a little bit more streamlined, and the patient's body will do the healing. So I like using the Osteo toe implants to fix hammer toes. That's what I like to use for that. And for bunions, I'm a fan of lapiplasty. I mean, like I said,
yes, we've heard about the lapiplasty.
Here's the thing: like, if you want a biomechanically sound foot, which means if you want to stand up on the ground and not have your toe go like this, like no amount of soft tissue balancing is going to fix your bunion. People have come to me with ridiculous things they buy on Amazon, and they screw the thing.
The bunion splint. You've seen that one, right, Yolanda? Where the thing cranks the toe like this. And I'm like, y'all not in pain at night or having a spasm? I know you all are. Don't lie and say that works.
It does not work. It's like, I don't know who approved of this and who has all these commercials. So I saw the commercials and I'm like, this is such an elaborate, well thought out commercial for something that does not work. Okay. But anywho, I like the lapidus bunionectomy. I do use Osteo sometimes for the lapidus bunionectomies. So I'll fix it in the same way. Like I'll rotate the bone and make sure you have a good correction, and then fixate it with Osteo because they have awesome staples and screws and all that jazz. It's just, you have to be off of your foot for longer if you use that. But yeah, I'm a fan of a lapidus for bunions, and I'm a fan of fixating the hammer toes with the Osteo.
So we had a comment from in the audience that says, so socks don't work, no sis.
No.
Socks don't work.
Nothing works. No.
Yolanda, take it away, because I know you have a preference as well for your hammer toes and bunions. Tell us what you use.
Okay, so for hammer toe procedures, I go, like, if you need your hammer toe corrected, I do bone work. I go straight down to the bone. And so we will remove a small section of bone. I'm not big on fusions. I think it makes the toe look a little fusion? So I was going to get into that. So when you correct a hammer toe, you typically take out a small section of bone. You can either take out a small section of bone on, there's three bones in the toe, and you can take out one small section of bone out of one bone, or you can take a small section of bone out on one end and just take out the surface out on the adjacent end and mush those two together and have them grow together. Not crazy about that, because I find that it makes the toes look a little Frankensteinish. So I too use an implant, but but not but I use a pen that's dissolvable. I like the dissolvable pen that I use because it has some plasticity to it, so that if it unlike so a lot of people will use these K wires or Kirschner wires that will go from inside the body to outside the tip of the toe. Not crazy about those. Again, leaves the toes looking a little Frankensteinish.
Mhm.
Sometimes the toe looks a little twisted because I believe that when you use the power to drill through the bone, it twists the toes around. So sometimes the toes looks a little twisted in the end. So I don't really like using those. And plus, you're at a risk of getting what we call a pin track infection, which just basically means that because you have something that's traveling from inside your body to outside of your body, you're susceptible to having bacteria getting inside of your body. It's just the nature of the beast. So putting these small, tiny dissolvable pins to fixate or to hold the two bony fragments together is my fixation of choice. And like I said, I find that, like I said, even when I'm looking at it and I'm summing up what we call the normal parabola of the foot, and that's when you have it's okay for the second toe, and this is my explanation of the parabola of the foot. It's okay for the second toe to be either a little bit longer or shorter than the big toe, but then they should step downwards. You should be able to walk down, they should step downward. And so when I'm assessing what the parabola of the foot's going to look like, I look at it and I'm like, oh, is this toe bending this way? I can actually, because this implant is not super rigid, and it's not like these other implants, toe implants that they've had, because I've used it. Like I said, this straight out of residency, this is all I have done. I have just done only bunion and hammer toe surgery. So I have done this every kind of way. I've used every single kind of implant. And I have just come to the realization that using something as simplistic as this tiny little, plasticky implant that will dissolve away, which patients love because they're like, oh, there's not this metal thing in my body. It's not going to stay there forever. And then if for some reason, because, everybody's a little bit different, if you need to do revision work, it's really easy to revise the work. So that's, and it's also easy to use when I'm making I call it the interdigital approach, which is part of my tiara toe technique.
Question for you that's in the audience, Yolanda. Someone asked, how long does an implant last?
The dissolvable implants. So this, you know what? I'm going to just tell you, these what do you call them? The people that sell the stuff, they give you an answer, and I'm going to tell you, they're all liars.
I agree.
they're all liars. And I don't think that they mean to be. I think that it depends on you. It's just like when my patients ask me, oh, well, when am I going to be completely healed? And I will always say, I'll never give you a straight answer to that, because you're going to hold me to it. And so you're not getting a straight answer. So I can't give you a straight answer to that. I've seen a pin dissolved in the 3-month period that they say it should be dissolved. And I've seen an implant still there a year later. So the answer is, I don't know, but it will. But what I do know is that eventually it is something that will degrade down. It just will. But when it's encased inside of the bone, it dissolves down very slowly. If it moves, because anytime you put an implant into your body, it can fail, which means that it can move. So if it slips out and it gets out of there, now it's going to start to metabolize or break down a lot faster than it would if it's encased inside of the bone. So the degradation of that implant is very slow. That's my best answer. That's a great question. I'm so glad that they asked that.
Ebony, you want to comment?
Sure. I think the osteo stays in your body for 24 months before it's completely absolved. You won't see the osteo on an X-ray, so it's not something that I can be like, see, it's dissolved. You can't say that. You would have to get a CT or an MRI scan. Like if anything goes wrong, like if God forbid you fall or anything breaks after surgery, the only way to detect what's going on with the osteo screw is with a CT scan or MRI.
Absolutely. What do I like? The jack of all trades. Striker girl. I haven't had the pleasure yet of using osteofiber, but I intend to because I read great things about it, and I love the things that are absorbable. Other companies that will throw out Osteomed, I've used them, great products. Arthrex, great products. There's so many. Lapiplasty I've done for bunions. Stryker has Lapifuse. So I like to say that I would customize it to the patient. That's number one, because not everybody is getting everything. And I also, because of the type of practice I have with insurances, I am sometimes beholden to them on what they will and will not allow us to use, which, Ebony, I know you get.
All
So
the
that would be my answer. But I too like making sure, as my colleagues have said here today, well, we're trying to get you the best outcome possible.
I,
And
I just also want to add something to that. So I talked about the toes, but I did not
Mhm.
talk about my bunion procedures. So most of the times when I do procedures, a lot of people are under the impression that they can only have one foot done at a time. I do bilateral procedures, which means that I do both feet at the same time. Now, even though I don't participate with insurance plans, I can accept a lot of insurance plans. So it depends on the type of insurance you have, and I can accept your insurance. So it's not that I can't take your insurance, I can't accept your insurance. It's just that I don't participate in your plan. If you opened up your book or went onto the website and tried to find me, you're not going to find me that way.
got it.
I
Okay.
have to find you, and then through advertising or social media or through SEO search, I do something to find you, the patient, and educate you about why I'm so wonderful. And that's how you guys find me. And then you send us over the insurance, and I'll be like, okay, I think we can work with that. Now for bunions, I will do something. So a Lapidus procedure or a Lapidus-like procedure works on the long bones that attach to the toes, which are called metatarsals. Works on that part of that bone that is closer to your ankle. I do a procedure that is closer to the toe, which allows you to weight bear. There are Lapidus procedures that allow you to weight bear, but I'm not sure there are Lapidus procedures where you can do both feet at the same time. Now, there are some people that have these super huge bunions that, like, Lapidus must be done. It must be done. But I find that, through, skill and over time, I would say about 85 to 90% of the bunions that are done can be done what we call distally, or a procedure that's closer to the big toe, which allows the patient to weight bear, which means that both feet can be done at the same time. And working out of a city like New York, like New York City, where there's a lot of rigor and people don't have enough time to have these two down times, these two OR times, getting the surgery a one and done is like a huge bonus. Like, they're so relieved. They're like, oh my God, I can get this all done at one time. I'm like, absolutely. Let's just do this. Let's get it done. And so I find that a lot of patients are so happy and relieved because they really are under the impression that they can only have one foot done at a time. And it's really not true. There are some insurance companies that will mandate that they can only get one bunion done on one day, but that is few and far between. Most insurance plans do not say that you can only do one foot at a time.
So there's a question that came, and I'll start with answering it and then let you ladies into it as we start to wrap up soon. So the question was, is there a hesitation to do corrective surgery on diabetic patients? So I will say corrective surgery is a big umbrella. And what does that mean? If you're talking about fixing somebody's bunion and hammer toe, absolutely. The things that I look for, and I'm sure my colleagues will comment accordingly, is we're looking at your hemoglobin A1C. How controlled are you? Are you sneaking that cake every night? Because we know by checking your hemoglobin A1C, you had too much rice and beans, you had too much, curry chicken, whatever the case may be. That's one of the indicators to find out how well controlled you are. There's other labs that we look at when we draw labs to see how healthy you are, your urinalysis, albumin, all those types of things. And if it is something that is elective and you are being seen by your primary care doctor or endocrinologist, usually they'll let us know this patient is not optimized for a corrective surgery. So we stop. We do not fight your primary care doctor because anesthesia is going to agree with primary care doctor because you wouldn't do well under anesthesia anyway. Then there are the cases where we're doing diabetic limb salvage. So for example, a patient may come in and have gangrene. There's no blood flow to that area. That area is infected. That area is necrotic. Usually, and Ebony and Yolanda can comment, I use endovascular surgeons. These are vascular surgeons that are trained to do endovascular surgery with small little incisions to snake down your leg and open up a vessel with a stent. Many people have stents in their hearts. You can have stents that hold open a vessel in your extremities. And so once the patient is optimized, and they're usually in-house, meaning they're staying in the hospital, then they'll give us a window that says it's our sweet time to go ahead and do the procedure that's necessary. So that's my quick answer. Ebony, you'd like to take that?
Yeah, I will echo what you said. I'm not doing surgery on diabetic patients who have an A1C over 8, and that's pushing it. I'd rather see it lower, but because I tell my patients, whether you have diabetes or not, it takes me less than an hour to do your surgery. It's going to take you at least 2 months for recovery. And with all the things going against you with your health, it could take longer and you could have infection. And this elective procedure that you decided that you wanted could take a left turn based off of your underlying health conditions, and you can end up with no toes. That's just a risk that I'm not willing to take with already, at-risk patient. Have I done surgery on diabetics? Absolutely. Have they been controlled? Yes. I love, this probably is a good time to mention that everyone who undergoes surgery is essentially asking for a small planned trauma to happen to your body. Like your body is going to have all the blood flow rushing to it, the white blood cells rushing to it. It's an automatic healing response that your body undergoes after surgery. So you have to be mindful of that. You want to be in the best shape possible going into an elective procedure. I do recommend something called Juven to my patients it's like a little bit of crystal light that you just pour in a drink a week before surgery, and then you can do it all the way until you're healed. It provides a lot of good amino acids and things of that nature. For our diabetic patients, they're most likely lacking that. So anybody who has surgery with me, I'll recommend that. But for my diabetic patients, I'm like pushing it. So that way we can optimize you like before I do surgery on you and like throughout the entire healing process.
Sounds great. Yolanda?
And so for me, I would say that I have a very unique patient population. Most of my patients that come in are super healthy, even the diabetics. I think that they are like on top of it. They are under control. I think that they are diabetic, like they are so controlled. They're diabetic just by medical history. They're either controlled from either diet and exercise, or because they're doing the diet and exercise and taking the medications like the way that they're supposed to. So I would say the handful of diabetic patients that I've had to perform surgeries on in the last 20 years or so, hasn't been a problem. They've been cleared without with there hasn't been a problem with clearing them at all. So I typically don't have sick people coming in looking for elective surgery.
So we have a last question, and then we're going to do a wrap up where we can find everybody. So I need you ladies to answer this in about 30 seconds to a minute or less. So someone asked, but I think we hit the topic, but we might need to clarify it a little for this
Mm-hmm.
question. What about corns on the small toe, that pinky little toe that everybody bumps in the middle of the night? I
So,
recall my mother actually having a bone removed for cosmetic reasons, perhaps. Yolanda, we'll start with you and go to Ebony. Comment
so
30 seconds to a minute or less.
highly unlikely that it was strictly cosmetic. Most doctors do not do strictly cosmetic surgery. My mantra is providing medically necessary surgery with a cosmetic result. So probably not cosmetic. I'm sure that corn on the pinky toe was very painful. They did not remove the entire bone. They removed a small section of bone to stop the friction and stop the bending, so to relieve the pain that your mother was probably having at the time.
Exactly.
Mhm.
Ebony?
Yeah, I would agree. Removing the bone associated with a callus is probably definitely medically necessary. Also, I do it's called Z-plasties in my practice, where if you have a contracted fifth toe, it's like sitting on top of all the other toes. Relaxing that tendon and kind of reconfiguring the skin on top can make it sit down a little bit better so it doesn't
Mhm.
get that corn. So that's just something to keep in mind if you're just like, oh, I don't have a corn, but my fifth toe is just weird. So they're options.
I will answer this in short questions. So sometimes you can have a corn known as a Durlacris corn that sits by the toenail. We can excise that out or remove that, and usually there's a type of device that is almost like a sanding rotary burr that can smooth that down. We may clip it with a device called a rongeur. So many ways to treat that if it's by the nail. When it's on the toe, where we're shaving down the calluses at home, which I don't always recommend, obviously, then we're talking about the hammer toe surgeries, as Dr. Vincent and Dr. Ragland and I have discussed. So many things to talk about, so many things to learn. This was amazing. I'm so happy that the two of you kicked off stepping forward with Dr. D. It's you bring so much to the table. I think I've seen some of the comments and people are quite excited. And so a couple of things that I want to say. First, Dr. Ragland, so people, you're in New York City and the DMV. Where can we find you for people who are like, I got to go see the pink haired lady? She's amazing.
So you can find me, of course, on Instagram at Fix Your Feet. I'm on TikTok as well at Fix Your Feet, but most of the stuff is on Instagram. I'm on Facebook, Fix Your Feet, Dr. Yolanda Ragland, and also fixyourfeet.com. I also have Fix Your Feet products. I have the Fix Your Fungal Nail. So let me tell you something. The Fix Your Fungal Nail. It is second to none. You don't need a prescription with it, and there's a money back guarantee. You can't get your money back with prescription medications.
That's right.
And take it from somebody who suffered with fungal nails, and I haven't even had a recurrence. I can't say that it's a cure, but it works super well.
Fantastic. Dr. Vincent, where can we find you?
I'm all over Instagram at Dr. Ebony. Same with TikTok, Twitter, YouTube. It's Dr. Ebony. Let's see, I have a Dr. Ebony website as well as my practice website called My OC Podiatrist. If you just look up drebony.com, it has a link to the My OC Podiatrist. So you actually have to spell out doctor on that website. So it's DOCTOR ebony.com. Yeah.
Fantastic. So people are going to ask, where can they find Dr. D? So Talks with Dr. D, actually giving a little insight, came from a breast cancer, which I'm a survivor, and came from an advocacy. But Talks with Dr. D has grown into Stepping Forward with Dr. D and another, my 501c3, Sisters on the Vineyard. So we are reconstructing all things Talks with Dr. D. So don't go looking for me because you'll only find stuff on breast cancer. In the next week, we'll be blowing up Also, this is a monthly show. We will be on every first Wednesday of the month, which next is, I believe, May 1st, I believe, which is going to be at 7 o'clock. We will be advertising through blackdoctor.org. The physicians coming on next time will be advertising, and obviously through all my social media. I love that we're here together, friends, as we come to the end of this show. What do I say? The mantra for Dr. D: walk strong. Thank you for joining us and see you next month. Thank you, ladies.
Bye.
Bye.